Hello everyone, this is Dr. Vaibhav. In the series of adult lines and tubes, today we'll be discussing urology related lines and tubes. Okay, so in urology there are only a few lines and tubes, so it will be a short session. It will be specifically important for FRCR shorts cases. So you should be knowing the ideal position and you should be able to identify if you see any displaced or migrated lines and tubes as far as the urology part of the system is concerned. So the first most commonly used urology catheter is a DJ catheter, double J stent catheter, which is the basic uses we all know. The most commonly used for to relieve ureteric obstruction in cases of stones, strictures, or tumors. It maintains the patency of the ureter after surgery of or after any procedure, facilitates urine drainage from kidney to urinary bladder. The course of the catheter, there are two ways. One is from the antegrade direction. Antegrade means from kidney downwards into the urinary bladder. Retrograde means from urinary bladder towards the kidney. So the retrograde double DJ stent placement is more common and it is usually done by the urology people. The antegrade DJ stenting is only done whenever the urology finds it difficult to spot the vesicuretary junction, or if there is any edema or some mass over there, if the urologist is unable to negotiate through the vesicuretary junction, then the intervention radiologist comes into picture for inserting TJ stent in the antegrade fashion. Okay, understood. So the antegrade TJ stent is inserted from the renal pelvis through the ureter into the urinary bladder, or if it is a retrograde insertion, then the urologist, what urologist does, he cannulates the distal ureter, and after the cannulation, digestion is the wire is pushed for upwards into the pelvic LCL system, and over the wire, digestion is placed. So it has a curved J-shaped ends at both the sides. One of them will be in the pelvic LCL system of kidney, and another another curve will be in the urinary bladder. What is the ideal tip position? The proximal end, it is coiled into the renal pelvis, and the distal end, it is coiled into the urinary bladder. The entire stent should lie within the ureter without kinking or any abnormal positioning. So what happens if there is malposition? So in cases of malposition, then if it is proximal migration, then there will be a loss of drainage. Patient might suffer from pelvic pain or hydronephrosis. What happens if there is a distal migration? The whole of the DJ stent you will see lying into the in the extended location of urinary bladder in the pelvis. So that will cause irritation of the urinary bladder and ineffective drainage. Kinking, obviously, if there is any kinking, then you'll and kinking with ureteric obstruction, then the patient will have further increase in hydronephrosis and upper hydroureter. Or if it is in the outside of the urinary bladder, then you might see some associated iatrogenic injuries such as hematoma, some urinoma formation in such cases. Okay. Coming to the nephrostomy tube, that is another most commonly placed percutaneous nephrostomy tube in the radiology department. So the uses of PCN tube is drains urine directly from the kidney. It relieves urinary obstructions such as stone, tumors, or strictures. It treats infected obstructed systems such as in pyonephrosis. Also, we frequently put percutaneous nephrostomy tubes, and it provides access for urology intervention. Sometimes, like we have discussed in the previous slide, if the intervention radiologist puts antegrade DJ stenting, does antegrade DJ stenting, then it is mandatory after putting a DJ stent to have PCN catheter in place for some days, so that if there is any associated blood clots or any debris within the pelvic LSL system, then the blood clots and debris will be drained by a percutaneous nephrostomy tube, and it will not cause obstruction of the proximal end of the digestion. Okay, what is the course of the catheter? It is placed through the skin, subcutaneous tissue, through the anterior abdominal wall or anterolateral abdominal wall, through the retroperitoneal fat, through the renal parenchyma into the calyx, and then into the pelvic LCL system. The ideal tip position should be in the pelvic LSL system for adequate and proper drainage of the pelvic LSL system of the kidney. So what happens if there is malposition? If that if this curled end lies outside of the kidney, then it will cause urinary leakage, poor drainage, and there might be associated urinoma formation. And if there is any associated renal parenchymal injury, then you will also see hemorrhage or hematoma formation in the perinephric space. What happens if the curled tip of the percutaneous nephrostomy tube is seen lying within the renal parenchyma? Then there are high chances of bleeding, associated inadequate drainage, or some pseudoaneurysm formation. If it is too deep into the ureter, then obviously it might drain, or sometimes because of the kinking, there will be poor drainage. Okay, and if it is dislodged externally, then there will be persistent hydronephrosis. The uh, the catheter will not be able to drain the system, pelvic LSL system. This is how the percutaneous nephrostomy tube looks like on the radiograph, abdominal radiograph. So this is placed from the anterolateral, not anterolateral, predominantly from the posterolateral aspect on both the sides. Then another tube which is commonly placed is Foley's catheter. So Foley's catheter, this is a schematic representation, usually placed via the penile urethra into the bulbomembranous prostatic urethra, and the tip of the tube the tip and the bulb of the tube should be lying within the urinary bladder lumen. What are the uses? To drain the urine from urinary bladder, monitor urine output in critically ill patients, and for bladder irrigation in cases of hematuria and post-surgery. The course of the catheter we already discussed. From the urethra, passes through the prostatic urethra in males and enter into the urinary bladder. Balloon is inflated inside the urinary bladder lumen to keep it in place. What is the ideal tip positioning? The tip and the inflated balloon should lie within the urinary bladder lumen. What happens if there is malposition? Sometimes what happens, instead of inflating the urinary Foley's bulb into the urinary bladder lumen, sometimes because of some iatrogenic mistake, or sometimes the Foley's catheter bulb gets inflated into the prostatic urethra or bulbomembranous urethra. In those cases, patient will have severe pain and associated hematuria. If the tip is not seen within the urinary bladder, then there will be poor or inadequate drainage associated with hematuria. Partial placement will have pericatheter leak, and if the Foley's catheter is placed for a longer time into the urinary bladder lumen, then it might act as a source of infection. Patient will have cystitis and other complications. Then suprapubic catheter is usually placed. The uses of suprapubic catheter, this is how the suprapubic catheter is placed through the anterior abdominal wall above the pubic bone, and the tip and the bulb should be within the urinary bladder lumen. Uses are when the urethral catheterization is not possible or contraindicated, such as in cases of trauma or pelvic floor injuries. Whenever there is long-term bladder catheterization is needed, so instead of putting the Foley's catheter, which has higher risk of cystitis or any associated complication, in such patients, suprapubic catheter is placed, commonly in cases of neurogenic bladder and urethral strictures. And also suprapubic catheter is placed in cases of post-operative urinary diversion. What is the course of the catheter? Is inserted percutaneously through the lower anterior abdominal wall. It traverses the pre-vesical space. This is the pre-vesical space, also known as space of Ritzius, and then the tip and the bulb should enter into the bladder lumen. Ideal tip position, the tip and the balloon should lie freely within the urinary bladder lumen for a proper drainage. What happens if it is malposition? This is important. If it is outside of the urinary bladder, then in the pre-vesical space, then there might be a leakage of the urine or poor drainage or risk of infection. If it is intraperitoneally placed, then patient might have peritonitis, might suffer from peritonitis. If it is is placed against the urinary bladder wall, then it will cause inadequate drainage, some injury to the urinary bladder wall, urine leak, urinoma formation in the perivesical space, and sometimes it might enter into the urethra. Patient might develop discomfort if it is placed into the prostatic urethra. This is how on the radiograph suprapubic catheter will look like. Yeah, so at the end, guys, I'll be uploading this similar session on FRCR Shorts YouTube channel. I'll be sharing the YouTube link and Telegram link in the description. So this is we have discussed urology related lines and tubes in adults in today's session. We'll be discussing maybe what else is remaining. I think CVS system is remaining. So we'll be discussing CVS system and other system. I think one more system is remaining. So we'll be discussing the in maybe tomorrow or the day after tomorrow. Thank you guys. Bye.